Welcome to the deep dive. Today, we're tackling a really interesting, well, maybe slightly unsettling topic for anyone with dogs or cats, intussusception.
Right. It's definitely a word you don't hear every day.
It's a bit of a mouthful, but in simple terms, we're talking about when one part of the intestine kind of slips inside another part.
Exactly like that. A good way to picture it is like pushing the toe of a sock down into the rest of the sock.
Okay.
And there are terms for the parts. The bit sliding in is the intussusceptum.
Intussusceptum, got it.
And the outer part, the receiving part, is the intussuscipiens.
Intussuscipiens, right. Okay. So for this deep dive, we've gone through quite a bit of material focusing specifically on this in dogs and cats. Our aim here is really to understand, what it is, why it tends to happen, what signs you should look out for, and importantly, what treatment looks like.
And we did find some, well, surprising details, like certain types being more common and even a specific breed connection.
Yeah, that German Shepherd link was really striking, wasn't it? It wasn't just a small increase. The sources suggest they're, significantly more prone to one particular type.
Yeah, that gastroesophageal type, it's quite remarkable. What's also fascinating, or maybe frustrating from a medical view, is that the exact trigger, it often remains a bit of a mystery.
Really? So we don't always know why it starts.
Not precisely, but the leading idea, the main theory, points towards some kind of irritation in the GI tract.
Okay.
Imagine one section of the intestine gets sort of hyperactive, contracting really strongly, right next to a segment that's much more relaxed, maybe not moving much at all.
Okay. So let's unpack that. This difference in movement, this hyperactive bit next to a relaxed bit, that's what causes the telescoping. It just pushes its way in.
That seems to be the mechanism, yes.
Yeah.
And it creates a physical blockage, obviously.
Which is bad enough.
Right. But it's more than just a simple blockage. The blood vessels get involved, and that's where it gets really dangerous. Well, think about the veins carrying blood away from the intestine. They tend to get squeezed shut fairly easily in this situation.
Okay.
But the arteries, which often have higher pressure bringing blood in, they might keep pumping blood into that trapped segment for a little while longer.
Oh, I see. So blood goes in but can't get out easily. That sounds like a recipe for trouble.
Exactly. You get this buildup of fluid and blood within the intestinal wall itself. We call that edema and hemorrhage.
And that pressure buildup, what does it do to the tissue?
It leads to reduced oxygen getting to the intestinal lining. That lining is quite delicate.
And if that goes on for too long, if the intussusception isn't fixed?
Well, that's when things get really serious. The barrier function of that lining fails.
Meaning leakage?
Yes. Bacteria and toxins that are normally kept inside the gut can escape into the bloodstream.
Oh, wow.
And eventually, the lack of blood flow, the ischemia, can cause sections of the intestine to actually die. Necrosis.
And if that happens?
That can lead to perforation, leakage of gut contents into the abdomen, and a really dangerous infection called septic peritonitis. It's life-threatening.
Okay, that paints a pretty serious picture. So who are we typically seeing this in? Which animals are most affected?
Well, it can occur in both dogs and cats, but our sources definitely indicate it's more common in dogs.
Right.
And as we mentioned, that German Shepherd predisposition for the gastroesophageal type is significant, something like 60% of reported cases in some studies.
Yeah.
They also seem generally overrepresented for other types too.
Wow, 60%.
Yeah. And there's maybe a slight suggestion of increased risk in Siamese cats, but the evidence seems stronger for German Shepherds.
Okay. What about age? Is it mostly older pets, younger ones?
It's definitely more frequent in younger animals, typically those under a year old.
Why is that?
It often ties back to some of the likely underlying causes like intestinal parasites or viral infections, things like parvo, which younger animals are just more susceptible to.
That makes sense.
However, and this is important, if we do find an intussusception in an older dog or cat,
Yes.
that's a big red flag. It really prompts a search for an underlying disease, things like intestinal cancer or some other abnormality in the intestinal wall that might be messing with motility.
Right. So in older pets, it's less likely to be just bad luck, more likely something else is driving it.
That's often the concern, yes.
And I think I read somewhere, is there something about male dogs being more prone?
Ah, yes, that came up. There was an initial thought, specifically for that gastroesophageal type, that males might be more affected.
Got it.
But more recent reports seem to be questioning that specific link. And for the other more common types of intussusception in the intestines, there doesn't really seem to be a clear sex difference in either dogs or cats.
Okay, got it. So we know what it is, roughly why it happens, and who might be more at risk. How would someone, spot this? What are the signs an owner should be watching for?
It really depends on where the telescoping happens. That's key.
Yeah.
Generally, the further upstream it is, closer to the stomach, what that's called ORAD, the more severe and sudden the signs tend to be.
Like those gastroesophageal ones in German Shepherds.
Exactly. Those are particularly acute and serious.
Yeah.
But the signs also depend on whether the blockage is complete or only partial. A partial one might cause more subtle chronic signs.
Okay. So what might an owner actually see at home? What's the history like?
Vomiting is a really common one, often a key sign.
Right.
You might also see diarrhea. Sometimes it has blood in it, either bright red, fresh blood, or darker, tarry-looking digested blood.
Yep.
Abdominal pain is usually there. The pet might seem uncomfortable, restless, maybe guard their belly. In some cases, you might notice their abdomen seems swollen or distended. Loss of appetite anorexia is common too. And if it's been going on for a while, you can see weight loss.
And these signs, they can come on fast or slowly.
Both. That's what can make it tricky. It can be very acute, happening over hours or a day. Or it could have been going on intermittently for weeks, even months, before a diagnosis is made.
Wow. Okay. So chronic signs don't rule it out. What about when the vet examines the animal? What might they find?
Well, they'll likely confirm that abdominal pain or discomfort when they gently palpate the belly.
Okay.
If it's a severe case or it's been going on a while, they might pick up on signs of shock or cardiovascular compromise, like changes in heart rate, pulse quality, or gum color.
And can they actually feel the intussusception?
Sometimes, yes. A vet might be able to palpate what feels like a firm, sort of sausage-shaped mass in the abdomen.
Ah, the sausage mass.
Exactly. But, it's definitely not always palpable, especially if the animal's tense or overweight or depending on where it is.
Right.
And there's that very specific situation with ileocolic intussusceptions, where the ileum telescopes into the colon.
Yes.
The inner bit, the intussusceptum, can sometimes actually stick out from the rectum.
Whoa, that must look dramatic. How do they tell that apart from, say, a rectal prolapse, where the rectum itself turns inside out?
That's a crucial distinction. A vet can gently try to pass a blunt probe, like a lubricated thermometer, alongside the tissue that's protruding.
Okay.
With a rectal prolapse, the probe will stop because it hits the fold where the rectum turns back on itself. There's a blind-ending pouch or fornix.
Right.
But with an intussusception protruding, the probe can usually be advanced further up alongside the tissue because there isn't that blind-ending fold right there. It's a really neat diagnostic clue.
That is neat. Okay, so we've covered the what, the who, the signs. Let's circle back to the why. What are the known triggers or underlying causes?
Broadly speaking, anything that disrupts the normal, coordinated waves of movement in the intestine's peristalsis can potentially set the stage for it.
Okay.
We know certain things are associated with it. Inflammation of the intestines or enteritis is a big one. That could be from infections, dietary issues, things like that.
Makes sense.
Recent abdominal surgery is another known risk factor. Sometimes the handling of the intestines can temporarily affect motility. Also, any disease within the wall of the intestine itself, what we call intestinal mural disease, like tumors or severe inflammation, can disrupt movement. And as we mentioned, intestinal parasites are definitely implicated, especially in young animals.
Right. Did the sources mention any really unusual or unexpected causes?
Yes, actually. This was quite surprising. There seems to be a link, particularly in dogs, with certain types of organ transplants.
Transplants, like kidney transplants.
Exactly. The sources mentioned intussusception occurring in a noticeable percentage, maybe 8% to 33% of dogs after kidney transplants, and also around 5% after bone marrow transplantation.
Wow, why would that happen?
The exact reason isn't fully understood, but the suspicion falls on the immunosuppressive drugs that these animals need to take after a transplant. It's thought these drugs might somehow alter gut motility.
Huh. That's definitely not an obvious connection. Okay, so let's say a vet suspects intussusception based on the signs and exam. How do they confirm it? Diagnosis must be tricky sometimes.
It absolutely can be because, as you said, the main signs, vomiting, diarrhea, abdominal pain, are so common to many different gut problems.
Right.
So working through the differential diagnoses is key. We need to consider other things like, well, different parasites, viral enteritis like parvo, bacterial infections, foreign objects stuck in the gut, inflammatory bowel disease, a twisted intestine, which is called mesenteric volvulus. That's another emergency. And, of course, intestinal tumors, especially in older animals.
And remembering that chronic signs don't rule it out.
Precisely.
Yeah.
Just because it's been going on for weeks doesn't mean it can't be an intussusception plot.
What about lab tests, blood work, urine tests? Do they help?
They provide really valuable supporting information, definitely. A complete blood count, or CBC, can tell us about infection or inflammation.
Like the white blood cell count.
Exactly. It might be high, suggesting inflammation or infection. Or it could be low, which can happen with certain viral infections like parvo, or sometimes with overwhelming sepsis, or it might even be normal.
Okay. What else from the CBC?
The hematocrit, or red blood cell percentage. It might be high if the animal is dehydrated or has bleeding into the gut lumen. Or it could be low if there's been significant blood loss, suggesting anemia.
And the biochemistry panel, checking electrolytes and organ function?
Very important.
Yeah.
We often see electrolyte disturbances, low sodium, low chloride, low potassium, because of the fluid losses from vomiting and diarrhea. We might see increased kidney values, what's called prerenal azotemia. That usually reflects dehydration, making the kidneys work harder rather than primary kidney failure.
Okay.
And we might see low blood protein, specifically albumin, if it's leaking into the damaged gut. Urinalysis often shows concentrated urine, high specific gravity, which also points towards dehydration.
Are there any other, maybe more specific lab tests?
Sometimes measuring blood lactate can be helpful. High lactate can indicate poor blood flow and oxygen delivery to tissues like the compromised bowel. Blood gas analysis might show metabolic acidosis, again from poor perfusion and dehydration. Although interestingly, if the obstruction is very high up near the stomach and the animal is vomiting a lot of stomach acid, they might actually develop a metabolic alkalosis. So it depends.
Fascinating. But lab work alone doesn't diagnose it, right? You need to see it. So imaging.
Imaging is usually crucial, yes. Plain x-rays or radiographs are often the first step.
What can they show?
They might show signs of an intestinal blockage, like loops of gas-filled or fluid-filled bowel. Sometimes you might even see a vague soft tissue mass where the intussusception is. But often, plain x-rays aren't specific enough to be certain.
Right.
In those rare gastroesophageal cases, the x-ray might show a mass in the chest near the diaphragm, which, as we mentioned, could be confused with something like a hiatal hernia, though the clinical signs are usually way more severe with the intussusception.
So x-rays give clues, but maybe aren't the final answer. What's better?
Abdominal ultrasound is generally considered much more sensitive and specific for diagnosing intussusceptions within the abdomen.
Ah, ultrasound. What does it look like on ultrasound?
It has a pretty classic appearance. If you image it in cross-section, it looks like a target sign or a donut, multiple concentric rings.
Okay, I can picture that.
And if you view it along its length, longitudinally, you often see multiple parallel lines, sometimes described as a pseudo-kidney sign, because it can vaguely resemble a kidney's layers. These signs are quite characteristic.
That sounds much more definitive.
It usually is. Occasionally, contrast studies might still be used, giving barium either by mouth or as an enema to outline the blockage on x-rays, but ultrasound is often the go-to now.
And if it does go to surgery or if tissue is examined afterwards, what does the pathologist actually see?
Well, grossly, they see exactly what we've described.
Yeah.
One piece of bowel telescoped inside another. And under the microscope, they'll see evidence of the vascular compromise, congested blood vessels, hemorrhage, edema. They'll see varying degrees of damage to the intestinal lining, potentially necrosis or tissue death. Depending on how long it's been going on, signs of inflammation, possibly extending into the surrounding abdominal cavity, which is peritonitis.
Okay. So we figured it out. We have a diagnosis. What's the treatment plan?
The absolute first priority is stabilizing the patient. Before rushing to surgery, you have to correct the dehydration and electrolyte imbalances. That's critical.
So intravenous fluids are key.
Absolutely essential. Aggressive 5E fluid therapy tailored to the animal's specific deficits and ongoing losses, like from vomiting. Good nursing care is vital during the stabilization phase.
Okay, patient is getting stable. What next?
Surgery is the definitive treatment.
Right. How urgent is that?
It's generally considered an emergency. As soon as the patient is deemed stable enough for anesthesia, surgery should proceed promptly.
And what does the surgery involve?
It requires a full exploratory laparotomy, opening the abdomen to get a good look around.
Why the full exploration? Just find it and fix it.
Well, you need to confirm the diagnosis, assess the viability of the affected bowel, and importantly, search for any underlying cause like a tumor or a foreign object acting as a lead point, and also check if there happen to be multiple intussusceptions, which can sometimes occur.
Ah, okay. Makes sense. And then what do they do with the intussusception itself?
The first attempt is usually manual reduction. That means the surgeon tries to gently squeeze or milk the inner segment, the intussusceptum, back out of the outer segment, the intussuscipiens.
Can that always be done?
Not always. If the bowel looks healthy and it comes apart easily, that's great. But if it's very swollen, stuck, or if the bowel tissue looks damaged, discolored, or non-viable,
Then what?
then manual reduction shouldn't be forced. In that case, the damaged section needs to be removed. That's called resection. And then the two healthy ends of the intestine are sewn back together. That's anastomosis.
Resection and anastomosis. RNA. Got it. Now, I think you mentioned something earlier about trying to prevent it from happening again. Entero something.
Enteroplication, yes. It's a procedure where the surgeon places sutures between adjacent loops of bowel to create gentle adhesions, basically tacking them together in an orderly fashion.
And the idea is that stops them telescoping.
That's the theory. It aims to prevent recurrence. However, it's a bit controversial.
Oh, why is that?
Because enteroplication itself can sometimes cause complications down the line, like obstructions or problems related to the sutures that might even need another surgery to fix. So if it is done, it has to be performed very carefully. Gentle loops, no sharp turns, making sure the sutures anchor in the strong submucosal layer, but don't actually penetrate into the bowel lumen.
Okay, so it's an option, but needs careful consideration and technique. What about medications around the time of surgery? Antibiotics?
Yes, prophylactic antibiotics, meaning given to prevent infection, are generally recommended. The choice might depend slightly on whether it was just a manual reduction, which is considered clean contaminated, versus a resection and anastomosis, which carries a bit higher risk.
Okay.
But usually a broad-spectrum antibiotic is given around surgery. Long-term antibiotics aren't typically needed afterwards unless there's evidence of ongoing infection, like septic peritonitis.
And what about drugs to help the gut move afterwards, like metoclopramide?
Ah, that's another area of some debate. Prokinetics, drugs that stimulate gut motility. Some vets worry that using them soon after surgery might potentially increase the risk of the intussusception happening again.
Oh, interesting. So maybe best to avoid them initially.
It's something discussed on a case-by-case basis, weighing the potential benefits against that theoretical risk.
Gotcha. What about aftercare once the surgery's done?
Post-operatively, the focus is on continued supportive care. That usually means ongoing IV fluids for a period, good pain management, monitoring for any complications. Diet-wise, if they aren't vomiting, they're often started back on small amounts of water and then bland food relatively quickly, usually within 12-24 hours. Activity needs to be restricted for maybe 10-14 days to allow healing.
And what are the main things to watch out for post-op?
The two big concerns are recurrence and leakage from the surgical site.
When do those typically happen?
Most recurrences, if they happen, occur within the first few days, but they have been reported up to about 3 weeks post-op.
Okay.
Leakage from an anastomosis site, if it occurs, typically shows up around 3 to 5 days after surgery, when the sutures might be weakest before full healing occurs. That leads to septic peritonitis, which is obviously a major complication requiring intensive treatment.
Right. Septic peritonitis sounds like a whole other deep dive in itself.
It really is, yes. Very complex to manage.
So thinking preventatively, is there anything owners can do to reduce the risk of intussusception happening in the first place?
Well, since many cases, especially in young animals, are linked to underlying gut issues, prevention really focuses on managing those risks.
Like what?
Like ensuring proper vaccination schedules, especially against things like parvovirus. Regular deworming and parasite control is crucial.
Okay.
And trying to prevent dietary indiscretion, stopping your dog from eating garbage or non-food items and avoiding sudden drastic changes in diet can also help maintain normal gut function and potentially reduce irritation.
Good general advice for gut health anyway.
Absolutely.
What about other potential complications besides recurrence and leakage?
Well, septic peritonitis is the most feared immediate one. Very rarely, if a massive amount of intestine has to be removed, we're talking usually over 70% of the small intestine.
Yes.
The animal can develop something called short bowel syndrome. This means there isn't enough functional intestine left to properly absorb nutrients, leading to chronic diarrhea and weight loss.
Okay.
It's thankfully quite rare, though.
Okay. So putting it all together, what's the overall outlook? The prognosis?
It's highly variable. It really depends on the cause, the location, and how sick the animal is when they first present.
Right.
Generally, intussusceptions further down the tract, say in the colon, tend to carry a somewhat better prognosis, perhaps because the systemic effects might be less severe initially.
Okay. And the worst prognosis?
Those gastroesophageal intussusceptions we talked about, they have a very poor prognosis, unfortunately. Mortality rates reported in the sources are really high, like around 95%. It's a devastating condition.
Wow, 95%. That's grim. But what about the more common intestinal ones?
For the typical ileocolic or jejunal intussusceptions, if diagnosed and treated promptly with surgery, the prognosis is generally considered good. Many animals recover well.
That's reassuring. Okay, so let's try to summarize the key takeaways here.
Sounds good.
Intussusception is this serious condition, the telescoping bowel. It's seen more often in young animals, often linked to gut upset, like parasites or infections. But in older animals, you have to look for underlying disease.
Correct. And German Shepherds have that significant predisposition for the very dangerous gastroesophageal type.
Right. Early signs like vomiting, diarrhea, pain are crucial to pick up on. Diagnosis often relies heavily on ultrasound showing that target sign. And treatment is fundamentally surgical, either manually reducing it or removing the damaged section after stabilizing the patient.
Yes, prompt surgery is key for a good outcome in most intestinal cases.
But the prognosis really varies, with intestinal cases generally doing well with treatment, while that gastroesophageal type is, well, extremely serious.
That sums it up well. Emphasizing the good prognosis for most intestinal cases, if treated early, is important.
Absolutely. So for you, our listener, this brings us to a final thought. Given all these potential underlying triggers for gut upset infections, parasites, diet, maybe even stress, what proactive conversations could you have with your vet? What steps might you take together to really minimize those risk factors and promote the best possible gut health for your own furry companions?
It's a great question to reflect on. Proactive care is always beneficial.
Definitely something worth considering. Thanks for taking this deep dive with us today.